Welcome to the show, Mandeep. This is Action Potential, episode one. You're my first guest, so I thank you a lot for being here with us to share your journey through the field of nephrology and many other things. Let's dive right in. Please tell our audience about you.
Fantastic. Thanks so much, Sahan, for inviting me, and thank you. I didn't realize that I'm your first Action Potential speaker, and congratulations for getting this going, and also congratulations for everything you've done so far, Sahan. I've
Thank you.
enjoyed this journey with you thus far. So, to your audience, my name's Mandeep Sahani. I'm a practicing nephrologist. I've been practicing for the last 20 years. Sorry, a little more than 20 years. 20 of those last 25 years have been in Phoenix, Arizona.
And tell us a little bit about your journey to get to the field of nephrology, Mandeep, if you can. What
Yeah,
were
of
what
course.
were some of the key influences that made you think, first I need to become a doctor, and I want to serve this type of patients, or what were kind of influences? Tell us a little bit about your journey talk, if you will.
Of course, Sahan. So, as far as back I can remember, maybe 10, 12 years of age, I always wanted to be a physician. I was then, even then, and even now, I'm the only physician in the family. I come from a well-established, big business family in India, and that's the path that I wanted to take. And my biggest supporter was my mother at that time. And uh, as I started med school, cardiology really fascinated and interested me. Everything about the physiology, the anatomy, how it's at that time I thought was the most central organ, and was quite fascinated by it. My journey was always right from the get-go. Wanted to come and train and learn more and be established and settled in the U.S. So when I arrived here, I arrived a couple of months late. The visa process is quite lengthy and tedious, and I was refused a couple of times. And then when I got accepted to a residency position in Chicago, because of the delay in getting my visa, I think I started about 3 months late, and then by default, I was put into work under do a rotation under the chief of medicine and also I think the chief of staff at that time, Dr. Bob Hedger, who happened to be a nephrologist. And back, in our training, medical school training back in the late 80s and the early 90s, had no exposure to nephrology. I just had a little bit when I did about a year or so in England at a very remote and rural hospital, but still I hadn't gotten my interest till I started the residency programs, till I started rounding with Dr. Hedger. I want to say it was a style of practice. He was from North Dakota. He imbibed the quintessential salt of the earth, Midwest ethics and philosophies of practice that really resonated well with me. And then as he started educating me about nephrology and how even the clinical practice of nephrology relies so much on your physiological fundamental principles. That's the first year that you study in medicine. That really, that along with his style of practicing medicine, very laid back, using data as a means of getting to a diagnosis, and not just data, but also all the clinical inputs. That just fascinated me. I can't think of a better word than that. And then I decided I want to be like Bob, Dr. Hedger. And so he helped me through my journey. He helped me write a couple of research papers. He introduced me to Todd Ing, who even then and now is considered the father of dialysis, has written multiple handbooks on dialysis. And so I was lucky enough to do a fellowship under Dr. Ing. And then once I finished my fellowship, I remember this, he just threw this application in my lap and says, "You need to go work here." So I said,
Okay.
"All right, Dr. Ing." And where was that? That was in a small town in Sioux City, Iowa, back in 2001. And I served the population there from 2001 to 2004. And that's where I was exposed to taking care and serving of the indigenous tribes there, the Sioux tribe and the Winnebago tribes. Serving them made me feel very much at home. Their culture, their approach to their physicians, their approach to medicine. And I got a position and offer here to come to Phoenix in 2004. And one of the things that I was interested in is because they had and they still have a pretty significant presence with tribal communities and serving tribal communities and serving the rural communities around the metropolitan Phoenix areas in Maricopa County. So I took the job, and this was back in 2004, and here we are in 2023.
That's all. That's an amazing story about how your first job in Iowa influenced how you would see the field of nephrology moving forward for the next 20 years now, almost to next year. Can you talk us a little bit through what it's like serving underserved populations, particularly in the U.S.? We see, particularly in kidney care, huge disparities in how care is delivered to people with lower socioeconomic status, rural areas, some major challenges associated with that. How have you experienced delivering care? What are some of the important aspects of that you always need to consider when you think about providing the best version of care for these people who are underserved today?
Right. So my outlook to that is I think it's mostly access to care and access to specialist care, which unfortunately is not that available in rural communities. Even though these rural communities may, at least in our case in Arizona, where we are, may just be about 90 miles away from the urban Phoenix and adjoining the suburban areas.
Mm-hmm.
Nephrology as a field and nephrologists are shrinking in number. The burden of work and the burden of illness that nephrologists face to take care of these highly complex and highly sick patients sort of stretches us a little thin, and it develops an inability for us to serve our patients in the capacities that we were trained to serve them for reasons that are unapproachable given the geographical distances. And also, if we are there, then if you decide to be present, boots on the ground, then having facilities like we take for granted in other big hospitals, dialysis within a rural community or rural hospital is much desired. So
Right.
it's very fulfilling to sort of try and come up with ideas that bridges that gap. And you very well know, Sahan, you're in this space as well, using technology and now even using telemedicine. How do we get to see our patients, even though it may be just maybe once or twice in a couple of months, but deliver that pertinent information to the patient, deliver that pertinent missing care and bridge that gap. I think that is fascinating, is avoiding that particular patient to move out of his community, out of his where he's most comfortable with, out of his home to get care that's not available, that's we in the metropolitan areas take for granted. I think providing that service and closing that gap brings immense satisfaction.
That is very interesting, Mandeep, to hear your perspective on that. What role as a nephrologist do you play with these patients that you serve? Then, are you the empowerment piece to the patient to take better control of their health? Are you the cheerleader? Are you the gatekeeper? What can you speak to us a little bit about how you see the role of the nephrologist? Um, uh, in how you serve these patients, particularly with the challenges that you just mentioned in mind?
I think you've said the magic word, which is empowerment, and I think that's really powerful, and that's in my lexicon, and that's in the approach on how the style of medicine that I love to practice is arming the patients, arming the community with the necessary tools, necessary information, the necessary knowledge, and the education, so that they can be empowered and understand and take care of their own health. I think many times we as physicians, forget that we are also healers, and having the ability to engage with your patients and switching on that healing button, so that, which in other words, could be exactly what you're saying, is empowerment, getting them focused on these are the next steps that he or she needs to take to improve his or her clinical situation, so that they can get out of that disease state that they're in and improve their lives by education, by adopting certain skill sets, by teaming up with the right people, and also not just helping just themselves and their family, but uplifting the community as well. I think empowering our patients, empowering the community, especially in rural areas where you take a community-based approach, can get you good results.
Yeah, I can certainly attest to that based on the feedback we've heard from patients as well, Mandeep. One of the sticking to the empowerment piece, how does technology help you as a physician make sure that the patients feel like they have the right tools to stay on top of their health, take preventative action? We look into the space of chronic kidney disease and dialysis today. There's a tremendous push to move dialysis to the home, which sounds exactly as you mentioned is a key focus of yours, to help patients have the right access to care from their own home. We see many medications come to market that are disease modifying for the better. Um, can you speak to us a little bit about the state of nephrology right now and how you think technology can help you empower your patients better a little bit more?
Of course. So there's a really big focus on, if our patients do end up getting on ESKD, if they do develop ESKD and they do end up needing dialysis, that supports their longevity. Uh, Being able to provide dialysis at home is where I think a strong healing process can begin. Uh, Technology has changed that with having you know user-friendly machines, simplifying to where with a just a point and a click, they can start their own dialysis at home. They can be around their loved ones at home. They can schedule dialysis to their uh, uh, schedule, and then also imbibe that healing environment in their own home. Be around with their pets if that's okay. Be around with their plants. Just absorb the energy that they are in a very comfortable surrounding. It impacts the healing. Uh, Technology is at the forefront of this. That has definitely changed our approach to and shift from in-center dialysis to dialysis at home. Being able to monitor these patients remotely when they are at home through and good solid internet connection, being able to see their vitals in real time, being able while they're on dialysis or even when they're not on dialysis. I think that gives the patients a fantastic degree of comfort that even though they're not in a conventional dialysis setting, which is an in-center setting, they are still being taken care of. They still have virtual eyes on them, and then their vitals are being measured at the same time as they're going through this 3 to 4 hour procedure, sometimes 3 to 4 times a week.
I want to come back to that point in a second, but before I do, I want to ask you one question around the focus around home dialysis often starts before a patient needs to start dialysis. At least that's how uh, there seems to be best results oriented. Once someone starts in center, there's of course incentives to move both for patients and for providers to move patients into the home. But oftentimes that journey of recognizing dialysis might be imminent, and starting at the home has its benefits is one aspect. But I also want to ask you about um, preventative care. How do you think about preventing these patients from ever needing dialysis? And what are some of the key technological advancements you've seen that can help you do that?
Excellent. So the idea is that our first focus as nephrologists is to slow down the progression of CKD as and when CKD sets in. And then if they need dialysis or if they're eligible for a kidney transplant, that'd be the first option other than getting dialysis in center. But moving upstream is how do we, decrease the disease burden so we can slow down the progression of CKD towards dialysis. Now, here in the U.S., the two most common causes of CKD and ESRD are diabetes and high blood pressure. So how do we monitor these two disease burdens and decrease the comorbidity on our patients when number one is they're remote, and number one as specialists we see them maybe once or twice a year, especially in the early stages. Now, remote patient monitoring or remote physiological monitoring, through these newer devices, and while they're connected through cell phone lines or through the internet, we can monitor their blood pressure. Right, and blood pressure, as stated earlier, is one of the leading causes of CKD and kidney disease in this country. We all know and we all love continuous glucose monitoring. This way, the patients in real time can know after they've eaten perhaps what they think could be a carbohydrate poor meal, or end up actually spiking their sugars, and then they know they can adjust their meal in the next time go around. If that's something that they like to consume, maybe decrease the portions a little bit so they can see better results of their sugars, and then in return of their hemoglobin A1Cs. But as you know, Sahan, for CKD progression, not only do we have to develop the ability to control their sugars, control their blood pressure, but also as there's decrease in kidney function, it's important to keep an eye on other electrolytes like sodium, potassium, bicarb, etc.
And how do you do that today, Mandeep?
So at the moment, it's done by a blood test. You have to go to a lab, or you can have somebody come at home and a phlebotomist collect the blood, spin it, and get results depending upon. Either it can be stat results, can be done within the next few hours, or usually the results come by within 24 to 36 hours.
Mm-hmm. So does that suffice at different stages of chronic kidney disease? Like you said at the very beginning, when you see a patient who's at an earlier stage of chronic kidney disease, who have more diabetes and hypertension related management, you have remote blood pressure monitoring and CGM, continuous glucose monitors. But as they progress through chronic kidney disease, their electrolyte imbalances tends to be more severe. So do blood tests, in your opinion, suffice for managing patients, particularly those who are remote and not necessarily in places with great accessibility to laboratory tests and clinician care?
Yeah, exactly right. I mean, if there is, I'd like, as their CKD disease progresses, and they are at a point where they are, nearing dialysis, but still not there, it's imperative that we not only control their fluids, control their carbohydrate ingestion if they're diabetics, make sure their salt and water is balanced so that the blood pressure stays controlled through remote physiological monitoring. But it's one of the electrolytes that is pretty ubiquitous in our diet is potassium. Potassium, on both sides, whether it's too low or too high in a body fluids, can cause problems with the heart and muscles. Many times, we have to restrict that diet. We tell our patients not to eat tomatoes and potatoes as the CKD disease progresses, because of these reasons of avoiding the consequences of hyperkalemia or high potassium. But as you mentioned earlier, we don't get that often to test them with the blood test to see if this particular food ingested in this particular quantity in this particular stage of CKD is going to affect their potassium one way or the other. There's always a time lag, and if the test after they've consumed the meal and the test results come back, in a day or so, sometimes it's a little too late to take action. And then what has the patient learned from it, right? He's learned, okay, I got to give up my a food that I love completely, right? So I don't get into dangers of a high potassium state. So if we had something that we could, just like we monitor continuous glucose monitoring, if my late CKD patients had the opportunity to monitor the potassium in a continuous manner, once again it empowers them, educates them, and they know that they can limit the food that they like and get a real time result on what the monitor can
It's really
read out.
interesting. We are often told as hypertensive patients not to consume sodium, reduce your salts, but sodium and potassium work quite in unison, but in very different ways. Just like you should avoid high sodium foods, you should not avoid completely cutting off potassium just because you're afraid that you could go into hyperkalemia. There's always a moderation in how you need to consume these just to maintain blood pressure. Did I hear that correctly from you? That fluid balance through electrolytes is really important for to maintain appropriate blood pressure levels, so you're not stressing your kidneys.
Exactly right. So that's where sodium and salt comes in to maintain, your volume status, and volume is reflective of your blood pressure, and having a higher blood pressure can obviously detrimental to the CKD progression. Uh,
Now, on the thread of electrolyte management, suppose you can now see potassium and sodium and key electrolytes that allows you to and the patient to maintain their fluid balance. What key actions as a clinician can you take, and what key actions will you empower your patient to take, Mandeep?
So if I know through, once again, through remote patient monitoring or remote physiological monitoring, my patient's weight has gained, he's gained a significant amount of weight in a short period of time. The first thing I'm going to ask him is, what is your salt consumption? Are you restricting sodium in your diet? Are you restricting fluid intake? And that way I can gauge whether I need to educate him about decreasing that or increase his diuretics so he can get rid of the excess salt and excess water. If it comes to potassium, at the moment, I don't have something that is suggestive or a surrogatory marker of a potassium. I need to know what that value is. So, short of sending the patient to if to the lab to get his blood tested for high potassium, if he or she says that, okay, I had an orange, and calls me up, and then we send a requisition to the lab, and the lab does a test. So there's a lag between him or her having an orange, not realizing that that's not good for him or her, and then me getting the result back. There's a significant lag, and there's opportunity lost there, right?
Right.
Now, if we had something like a CGM in this instance, I would know the result right away. And instead of the patient wondering, then somebody at my end could call the patient and say, look, your potassium spiked. Is it something that you ate? Or is it a new medication that somebody started? Or, hey, did you remember that we mentioned in the past not to have any, high potassium foods? So that then is a feedback, learning loop for the patient. All right, the next time, I need to avoid this because I just ate the orange, like 2 seconds,
Right.
2 minutes ago, right? So the
Right.
lag time is shortened.
And it becomes a learning journey for the patient to also figure out how their own body works, so that
Exactly,
they can start to make the decisions for themselves on what they like to eat, but in moderation, or when to do it. So it becomes really learn and optimizing intake behaviors that then feeds into the lifestyle that they want to lead.
exactly. So
Yeah.
if I'm the patient, I know the next time maybe I just have two slices, and I can know that my potassium level won't rise to a level where I get a call from my physician or his team.
So, tell us a little bit about what excites you about the world of kidney care that you foresee in the next 5 to 10 years to come, Mandeep. Well, clearly
So
you have these ideas on, what would help you empower your patients to stay, if they're earlier stage in chronic kidney disease, that they would retain their kidney function for as long as possible. But if they're coming close to, starting dialysis, then potentially home dialysis empowered by safety aspects of that, because you're taking away the in-center care team around a patient. You've spoken to us about many interesting topics around where remote patient physiological monitoring can also help. But what excites you? What do you think are big things to keep an eye out on in the field of nephrology in the next 5 to 10 years to come?
I think firstly, there is not much recognition of chronic kidney disease, right?
Mm.
Some people will say, some nephrologists will say it's not as sexy as cardiology or oncology that gets all the limelight and gets all the healthcare industry behind those disease states, right? But as of late, in the last few years, we've seen a tremendous spotlight on CKD and ESKD. A spotlight in the sense, what is the spend on this diagnosis, both when they are on dialysis and before dialysis. The idea is that most of CKD here in this country is caused by either diabetes or hypertension,
Mhm.
but you know, 1 in 7 patients may have CKD.
They just don't know about it.
They just don't know about it, and the 9% don't know about it. So the first thing is education, and how do you start that education? After education, then initially there's a lot of hand holding that has to be done by the healthcare community, the provider community, and part of that hand holding is then to empower these patients, and then to create programs that would help decrease their comorbidities, help decrease their disease burden, and then but those programs need the right funding and the right approach. And I wouldn't say that we develop newer funding mechanisms. I think just alter the ones we already have, whether it's through for our patients above 65, whether it's through Medicare or whether it's through Medicare Advantage plans. How do we create a robust care management platform through Medicare Advantage plans or through just traditional Medicare that has a niche focus on CKD and what causes CKD, like diabetes, congestive heart failure, hypertension. And then at the same time, if they do end up on dialysis, how do we create a program that enables these patients to get, number one, dialysis at home, right? Because then we believe there's a good chance that they're going to be more compliant. If they're more compliant, that decreases their pill burden, therefore decreases their cost, and also decreases their comorbidities, decreases their chance of getting in the hospital. All that data has been, clearly shown. But
Mhm.
it starts with a focus on this, which
Yeah.
I think we're starting to see, focus on CKD and ESRD.
And the goal would be to do it before it's too late and a patient is in need of dialysis. So the earlier you intervene, the the more touch points you can have and hand holding such that the patient still has a long time to go where they control their own destiny in terms of their disease burden and how they live their life to their
Totally agree.
fullest.
Totally agree, Sam.
And you must still be very excited based on the last couple of years, Mandeep, seeing venture backed companies raise close to, if not more than, 2 billion just to focus on this big issue, even though there are some major hurdles ahead of all of us to change how nephrology is delivered. Any last takeaways? Any last things you want to share with our audience as we bring this interview to a close?
No, firstly, thank you, Sahan, for giving me this opportunity. I love the term action potential. I think it speaks a lot. It's a call to action, number one, and we have to collectively create the potential to be able to get to things we mentioned above, right? Which is definitely recognition of and awareness, and then creating pathways and programs to slow the CKD progression down. So then we can then give this program not just in our lifetimes, but hopefully in futures to come. And clearly, there is more spotlight on our specialty, more spotlight on this space. You might have read recently about the xenograft from a pig kidney, right? So we're very excited. I think we are. I like to think at an inflection point with everything else that you mentioned. We're seeing good funding coming into this space.
Yeah.
I think the next few years are going to be very interesting, and I'm glad to be part of it.
Absolutely. Well, as one of the leading nephrologists in the country, we thank you for joining us today to our first episode of Action Potential. Mandeep, thank you very much, and look forward to seeing a lot more from you in the coming years.
Likewise, Sahan. Thank you for
Bye.
your support. Thank you.
Thank you.